Clacam, but as Massimiliano is in a meeting, we would kindly request him to start with Chiari formation or malformation. I've heard this talk before. It's wonderful. I think you guys would love it.
Formation or malformation. As a matter of fact, you know that this is invention of Professor Atul Goel, who was the very first to rise up the question if Chiari is a formation or malformation. As a matter of fact, if you look at into the literature, you can find different way to appear of the Chiari. Chiari is not tonsil below 3-5 millimeters, but more than 5 millimeters below the foramen magnum. Otherwise, it is an anatomic variant. We have to consider this cutoff. And first of all, we remember that Chiari in our very basic culture, Chiari 1 and Chiari 2 are two different concepts dealing with adult age and childhood. Chiari 1, only tonsils herniation without dysraphism and rarely with hydrocephalus. Otherwise, Chiari 2 is associated with dysraphism and hydrocephalus is typical of infancy. And Chiari 3, according to the very first historical definition, is a rare condition not compatible with life, with encephalomenincocele. Very more precisely, we can consider type 0 is a Chiari symptomatology without tonsillary herniation. 0.5 is just standalone syringomyelia with a very narrow posterior cranial fossa. Type 1 is the adult way to behave of Chiari without diaphism, without hydrocephalus, with a very narrow posterior cranial fossa, but tonsillary herniation more than 5 millimeters. 1.5 is a Chiari associated with the craniovertebral junction dystrophism, triple 5, basilar invagination, odontoid retroversion, and type 2 is the childhood typical Chiari condition with associated hydrocephalus and myelomeningocele. Type 3, as we have seen, is a cervical hernia. Type 4 is aplasia of posterior cranial fossa content. Who is the one to be operated? The one affected by clinical symptom. When when syrinx is associated with Chiari malformation, the compressive surgery is indicated. In neonates, is a surgical emergency. When, as soon as possible, since the pediatric type, Chiari 2, is very fast and very dangerous and deadly condition. How? Limited bone compression without opening of the dural wire when stand alone tonsillary herniation, otherwise
Sorry, Massimiliano.
associated with the
Excuse me,
syrinx
Massimiliano.
duroplasty.
Sorry,
And
Massimiliano. If you could just
while the
delete
compression
there is a
with
line at the bottom. If you could, there's a line at the bottom which says app zoom press. Please, if you can delete that line because that is coming in our way. We can't see that.
I hear some voice in the background. Yeah.
It's
And
okay. Carry on. Yeah.
is it a stable condition or reversible condition? Sometimes it's reversible, very rarely. We can see here that we have spontaneous resorption of the Chiari herniation as well as a spontaneous reduction of syringomyelia. Very rare but possible cases are recorded into the literature. In August 2022, with the Delphi method, we had a very interesting meeting of expert opinion chaired by Professor Salman Sharif. And in that occasion, I faced with the surgical indication for Chiari malformation. And Chiari malformation must be operated when the patient is harboring a headache elicited by Valsalva maneuver with syringomyelia, with foramen magnum cranial nerve dysfunction. And the mechanisms are compression and traction. We tried to systematize all the driving forces managing this rare condition in our paper, but the best summary of the surgical alternative was done as a fruit of the consensus conference in spine and also in brain sciences. We tried to further investigate and highlight to the special condition of Chiari 1. And but returning back to compression, compression is primarily due to small posterior cranial fossa, and the therapy is opening posterior cranial fossa and also performing duroplasty. Second mechanism can be hydrocephalus. To operate hydrocephalus is the requisite to cure both ventriculomegaly and syrinx dilatation. When we operate the hydrocephalus, the syrinx disappears as well as the tonsillar herniation. Craniosynostosis also a pathological condition narrowing the volar skull base, but cranium, but also and mainly the posterior cranial fossa. Abnormality of the upper cervical spine, critical 5, basilar invagination. And here the concept of instrumentation and fusion of C1, C2 complex is the new revolutionary vision and interpretation of my friend Atul Goel. You can see before instrumentation and after instrumentation. But I had a personal experience that someone what seems to contradict this experience. In my personal experience, I have a young guy, 8 years old, with platybasia, basilar invagination, bifidism of C1, tonsillar herniation. After a transoral decompression, you can see here the complete disappearance of the clivus, C1, and the odontoid, with the disappearance of the tonsillar herniation. But surprisingly, this is the first case recorded in the literature. We have a growth of the odontoid and the clivus, as well as regrowth, a recurrence of basilar invagination. So this patient was fixated after odontoidectomy, was one stage combined fixed of C0, C3. Nevertheless, the patient had a recurrence of the tonsillar herniation. And this is a very interesting case to speak about and to think about, in my personal opinion. Then we have arachnoid fibrosis, and this is what happens after opening of the dura when you have a subarachnoid white fibrosis. That one must be removed and corrected. The second mechanism beside the compression is a traction. Traction as is tethered cord. Tethered cord, we have a normal size of posterior cranial fossa. Nevertheless, we have a herniation of the tonsillary systems through the foramen occipitalis. And the Barcelona neurosurgeon Rocco strongly advocated the need to cut the filum terminalis in order to cure 100% of Chiari malformation. But according to the Italian Society of Neurosurgery, we have a first negative position of an national society against this strategy. And also, the literature is quite confusing because we have this paper with the group of Milorat and Bolognese pushing and proposing the filum terminalis removal as a possible therapy and cure for moderate degree Chiari malformation. Nevertheless, we have Massimi of our institution, Catholic University of Rome, Pediatric Neurosurgery section, and he is quite controversial in his conclusion. And finally, a group of Milano de Oliveira stated that there is no scientific support for the filum terminalis resection. And finally, and we so conclude our presentation, we have the idiopathic intracranial hypotension as a traction mechanism for Chiari malformation. The idiopathic intracranial hypotension is a special rare condition where we have to deal with a low CSF volume rather than a decrease of pressure. And the neuroradiological setting of this rare condition is epidural CSF collection along the nerve roots and also retrospinal CSF collection. We have subdural fluid collection, hygromas, hematomas, or enhancement of pachymeninges that can be uniform or diffuse. We have also engorgement of venous structure and pituitary hyperemia, as well as sagging of the brain. In other words, a descent of cerebellar tonsil through the foramen magnum. All these neuroradiological signs are consistent with idiopathic primary idiopathic intracranial hypotension as a driving force, like a sucking force that promotes the tonsillary herniation through the foramen magnum, which is the therapy conservative with caffeine, bed rest, or epidural blood patch, or a fibrin glue patch, or direct occlusion, as occurred in our personal experience. And this consensus conference of 2019, in which I was one of the participants, conclude that symptomatic Chiari malformation must be operated, asymptomatic wait and see. When you have asymptomatic without syringomyelia, follow up. When you have syringomyelia, you have to decompress with duroplasty. When you deal with 1.5 Chiari malformation, first of all, you have to evaluate stability or instability. Just in case of stability, to decompress by anterior approach and stabilize posteriorly. In case of instability, just fix and stabilize with the hardware according to Professor Atul Goyal theory. So I thank you so much for the kind invitation.
Thank you, Massimiliano. I think excellent talk as always. I'm sorry there was a lot of disturbance at the background, and I know you are in a meeting, so it wasn't possible to have a clear room. But thank you for your talk. In